Good afternoon, everyone. I'll be presenting GFAP antibody-associated optic neuritis. It's not moved. So, 25-year-old female presented to us with a history of seeing bright visual objects in both the visual fields since 4 months. In the last 2 months, she also gave history of blurring of vision with transient visual obscuration in right eye, which was gradually progressive, and there was also mild blurring of vision in the left eye. The complaints were not associated with any pain, fever, headache, any sensitivity to light, nausea, or vomiting, no history of any muscle weakness, numbness, tingling, dizziness, and there was no history of any trauma. She initially presented some other eye clinic where she was referred as a case of idiopathic, she was diagnosed as a case of idiopathic intracranial hypertension, and thereby referred to us. On further history taking, there was no history of any systemic illness, no history of any drug intake, no similar history in the family, and she was a mixed diet, no history of any smoking or alcohol, bowel bladder habits were absolutely normal. A patient was of average build with a BMI of 24.2 with normal BP and pulse rate. On CNS examination, patient was conscious and well oriented to time, place, person. All the cranial nerve examination were normal except for the optic nerve. There were no presence of any involuntary movements. On eye examination, right eye had a best corrected visual acuity of 636. In the left eye, it was 6/6. The color vision in the right eye, the recognition slide was not red, and it was 20/20 in the left eye. Pupil in both the eye were, the iris pattern was radial both eye, normal in color. The pupil had RAPD of grade 1 in right eye, whereas normal pupil reflex in left eye. When the patient presented to us, this was the fundus examination. The right eye showed nasal margin mildly blurred. The cup disc appears to be 0.6:1 with more pallor as compared to cupping. And the left eye had disc margins blurred in all the quadrants with hyperemia. Pattern lines were seen in both the eyes. This is the fundus picture of that same patient 1 week back when she had presented to some other eye clinic. At that time also in the right eye there was nasal margin blurring, obscuration of vessels, and the left eye the entire disc was elevated and the vessels were obscured the disc margins. This is the OCT RNFL of the same picture, of the same patient. Right eye showed, left eye showed disc edema, and the left eye, in the right eye there was nasally slight elevation of the RNFL. The left eye, when we entered with the macular GCC, both the eyes had significant thinning in all the sectors. This is the previous RNFL OCT RNFL and GCC of the same patient, in which both the eyes had bilateral disc edema. And at that time, the macular GCs in the left eye were relatively better as compared to right eye. This is the visual field of the same patient. Right eye showed superior altitudinal defect, and left eye was within normal limits. So we entered with blood investigations in which the CRP and the ESR were elevated. We investigated for all the atypical optic neuritis. So ANA, ENA, RA factor, and serum NMO and MOG were negative. Since the patient had seronegative, suspecting seronegative optic neuritis, so we went ahead for all the infectious and inflammatory causes, which came out to be negative in chest X-ray, the TRI-DOT, ECG, echo, and carotid Doppler. CMRI brain with orbit showed right eye subtle thinning of the right optic nerve, but there was no post and contrast enhancement, and the other segments of the brain were within normal limits. In the VEP, right eye showed reduced amplitude and prolonged latency, and left eye were within normal limit. In the CSF cytology, there was 100% lymphocytes found. The proteins and sugar were within normal limits. So this gave us a picture of inflammatory CSF cytology. All the infectious etiologies were negative in the CSF. We then went ahead with the GFAP antibody testing, in which the CSF GFAP were negative, but the serum GFAP came out to be positive. Since the GFAP is associated with a lot of neoplastic associations, so we went ahead to rule out any malignancy for which we have got done USG abdomen. And there was an incidental finding left ovary hemorrhagic cyst. She was advised CCT abdomen as well, but there was no evidence of any malignancy. And the gynecology referral was done, for which no immediate intervention were needed. Rest all the parameters were negative. So initially, we treated patient with IV methylprednisolone 1 gram OD. And once the patient was found to be GFAP positive, we shifted to IVIG 2 mg per kg for 5 days, and then switched over to oral prednisolone with slow tapering. So currently, the ocular findings were 636 vision in right eye with the impaired color vision. The pupils were grade 1 RAPD, but disc edema resolved in right eye as well in the left eye. This is the OCT RNFL picture, and the macular GCC showed thinning in both the eyes. Thank you.
Thank you. So, what are you trying to kind of highlight by this case? What exactly was your key message with GFAP associated optic neuritis?
So firstly, sir, in the seronegative optic neuritis, we should go ahead with the CSF cytology, and we should keep in mind the differential diagnosis of GFAP-associated optic neuritis. And secondly, if the patient was found to be GFAP positive, since it can be associated with other systemic diseases as well. And the neoplastic association is also there, so we should evaluate for that.
Any outcome differences with the other types of optic neuropathies and neuritis? MS-related, MOG, NMO?
So normally, if we give an initial treatment, so the relapses are relatively little less in GFAP as compared to NMO and MOG.
Where did you get GFAP done?
Ma'am, it was done in Lal Path Lab, we advised. So they do.
And what method was it?
Ma'am, it was IHC. They have done. They have got it done from there only.
Right, because normally CSF is more sensitive for GFAP
Yes,
as compared to serum. So it is surprising that you got it positive for serum and not for GFAP. That's first thing. Second thing, when you have GFAP, you have very severe disc edema. So the edema in your case did not appear to be as severe.
Okay.
So that is a concern. And how frequently do you see CRP and ESR so much elevated in cases of GFAP? Is it noted?
No, ma'am, not much.
So why didn't you consider other inflammatory pathology?
Ma'am, we investigated other inflammatory, like we have done the vasculitis profile. We have even ruled out other infectious causes. And after that, when everything was negative, then we went for CSF.
Yeah, but sometimes even you have these biomarkers as negative, these antibodies as negative, they may become positive later. They may be negative at baseline. So I think you may have to reconsider your diagnosis of GFAP over there. It's not so frequently to have this kind of raised CRP and ESR level in the cases of GFAP optic neuritis.
Okay, ma'am.
Thank you.